So we've dropped off at the first stage of labor where the cervix is dilating. And this second stage begins when the fetus begins to enter the birth canal. So the cervix is fully dilated, and now the fetus is entering the birth canal, and it ends when the newborn is completely born. So uterine contractions are usually much closer together, they last longer, and when we see crowning, which is actually the perineum that bulges significantly, that area between the vagina and the anus, and we should start to see the top of the fetus's head. So when we see that crowning, delivery is imminent. There's no going back. The baby is coming out when we start to see that crowning. Now, the third stage begins with the birth of the newborn and ends with the delivery of the placenta. So the placenta must completely separate from the uterine wall before it's delivered, and this can take up to about 30 minutes. So after the baby is born, at the end of that second stage, the mom will likely feel some immediate relief, and then she'll start having a few contractions again up to 30 minutes later. So it could be just a few minutes, it could be up to 30 minutes, and she will feel that sensation again and the urge to push, but it won't be as significant as it was with the baby presenting, and she should be able to push that placenta right out. You never want to pull on the placenta, on the umbilical cord, as it could cause it to separate, and that can be very dangerous, so we definitely don't want to do that. So how are we preparing for delivery? So we want to consider delivering at the scene when delivery is imminent. That means it's going to occur within a few minutes. Or if it's a natural disaster, inclement weather, or other environmental factors that would make it impossible for us to reach the hospital before the baby could potentially be born. So thinking about hurricanes, snowstorms, things like that. So to determine if delivery is imminent, we want to ask, how long have you been pregnant? So we're trying to determine how far along they are. When are you due? Is this your first baby? Because remember, the first baby is going to take a little bit longer. Everything after that will come a little bit faster. Are you having contractions? And if yes, how far apart are they and how long do they last? Have you had any spotting or bleeding? Has your water broken? You can also ask about a mucus plug. So have they had any type of mucus discharge? Do you feel as though you have to have a bowel movement? And that is absolutely key. And you're going to see several test questions related to that. If a pregnant female who you suspect to be in labor tells you that she feels like she has to have a bowel movement, you should not let her do that, all right? Because that urge to push the baby out is the same as that for a bowel movement. So we definitely don't want to let them go to the bathroom, as that could result in the baby being born in the toilet. So to ask about any potential complications, we would ask, were any of your other previous deliveries by C-section or cesarean section? Having a vaginal delivery after cesarean section is called a VBAC, or a vaginal birth after cesarean, and it can be dangerous. Some OBs try to allow women to do that because the healing process is a lot better. But sometimes it can be very dangerous because as the uterus contracts, the scar tissue that's on the uterus from the previous C-section can actually rip, and the baby can be expelled out of the uterus and into the abdominal cavity, again, making it very dangerous. The baby can't be born like that. So have you had any problems in this or any previous pregnancies? And that could be gestational diabetes, preeclampsia, preterm labor. Do you use drugs, drink alcohol, or take any medications? Is there a chance of multiple deliveries, so twins or triplets? And does your physician expect complications? Like, were you preparing to deliver at a high-risk hospital? We should prepare for delivery if the patient says she has to move her bowels or feels the need to push, or if you see crowning. So all of those things would tell us that delivery is imminent. Once labor has begun, it cannot be slowed or stopped. So we should never attempt to hold the patient's legs together, and again, never let them go to the bathroom. Remember, if you are delivering at the scene, you are only assisting the woman with the delivery. It's not a lot of work on your part, even though it feels kind of scary. It's the woman that's going to be doing all of the work. So most of the pressure should be on her and not on you. Now, in reference to the going to the bathroom thing, just understand that that's a very natural thing, that because you're using those same muscles often when the baby is born, so the woman will have a bowel movement as well. That's extremely common. So just prepare yourself with additional towels, and we're trying to keep the area as sterile as possible, but just reassure her and yourself that that is normal. So you should have a sterile emergency obstetric or OB kit, and this is going to look very similar to what you see here on the screen. So you see some pads there, you see some Chucks pads, you see some PPE in the form of gowns, gloves, things like that. You see the umbilical clamps. There is a scalpel. There's also a bulb syringe, and in this particular one, there's also a diaper. I've never seen one with a diaper, but obviously you're going to need one. So if they don't have one there at the house, we'll be wrapping some Chucks pads around that baby. For the patient position, you're going to try to preserve their privacy, especially if they're in public. So if they're at home, that's less of an issue. But if they're in public, then you do want to try to keep them as closed off as possible. We want to place the patient on a firm surface that is padded with blankets, sheets, and towels if possible. We're going to support the head, the neck, and the upper back. So having the mom lean up against the foot of the bed or on up against a wall, or if someone is sitting behind her. So have her keep her legs and hips flexed with her feet flat and her knees spread apart as wide as she can get them, or as wide as is comfortable. Then we're going to place the towels or sheets on the floor around the delivery area. We're going to open our OB kit and use the sterile sheets and drapes from the OB kit to try to make a sterile delivery field. And so that's what you see here in this picture, where they have the Chucks pad on the floor, and then they've got the sterile the sterile drapes over her legs and her abdomen to just try to keep it as clean as possible and for the baby. So with the actual delivery, your partner should be at the patient's head to comfort, soothe, and reassure, unless she has a family member, friend, or partner there that is able to do that. We want to continually check for crowning. Some patients will experience precipitous labor and birth, which means that it will seem like the head is coming out, and then it will all kind of go back in, and then it'll all come back out, and then it'll all go back in. Once the head is completely delivered all the way down to the shoulders, usually the rest of the baby will deliver itself, but up to that point, it can be kind of touch and go. So position yourself so that you can see the perineal area at all times. So you want to look for that bulging, and you're also trying to prevent any type of tearing in that area if possible. You want to try to time the contractions, and when she's having contractions, that's when you're going to have her push. So while she's having a contraction, you're going to tell her, all right, bear down like you're having a bowel movement, and count out loud for her. All right, she's going to be focusing on that breathing and pushing, so count out loud for her and have her hold that push just as long as she can. And then when the contraction ends, she's going to rest and relax and breathe until the next contraction. So while you're delivering the head, you want to observe the head as it exits the vagina, and you're going to support it with a gloved hand as it rotates. So ideally, it should come out face down. The baby can be born face up, but generally that's a more difficult delivery for the mom. What's most considered normal is going to be face down. So as the baby's head rotates, make sure you're not poking your fingers into their eyes or to the fontanelles or soft spots on their head. If you do see the amniotic sac first, if the baby is still in the sac and it did not rupture, you're going to need to remove it. So you need to puncture the sac with a clamp or tear it between your fingers to puncture it and remove the sac from the baby and get all of that fluid off of there. And then you're going to want to clear the newborn's mouth and nose immediately. So it's very important that you suction the mouth first and then the nose, okay? The reason being that babies are historically nose breathers, and so if you were to suction the nose first and the baby becomes irritated by that, the very first thing they're going to try to do is inhale to cry. And so if they inhale, they probably have some amniotic fluid in their mouth and already down in their lung tissue, or all the way down, moving down towards the trachea. So we want to try to get as much of that up as we can. And so suctioning the mouth first is going to prevent that inhalation. So if the umbilical cord is around the neck, again, this is not necessarily normal, but it is, it happens a lot. And so it doesn't have to be an emergency. If you notice that the baby is completely blue or limp, then that's where it's a little bit more of a concern. But if you see that it's just looped around there and you can get it off with getting a finger underneath, then you want to get that off. This is called a nuchal cord. So you would just gently slip that around the delivered head. If you cannot do that, if you cannot loosely slip it off, if it's so tight that you cannot get it off from around the baby's head, you're going to have to clamp it and cut it before the remainder of the baby can be delivered, because if you don't, the baby's not going to come out. Okay, the harder that she pushes, the more it's going to pull on that umbilical cord, the more it's going to suffocate the baby. So if it's so tight that you can't get it off, you need to clamp it and cut it. And we'll talk about clamping and cutting in just a second. But remember, you need to do that first if it's so tight you can't get it off. Once the head is born and then the shoulders come, that's the widest part of the body. But once those are out, the rest of the body will generally deliver pretty easily. You should never pull on the baby, right? You want to allow the baby to be born as naturally as possible. Remember that they are very slippery and they are covered in a white substance called vernix caseosa. And that's to help protect the baby as they grow and also help to regulate their temperature and things like that. So you want to try to wipe that off. And so as we are drying and stimulating the baby, you'll be wiping some of that stuff off, but it is kind of white and kind of chunky. We're looking at post-delivery care. If the mother is able and willing, we're going to place the newborn on her abdomen so skin-to-skin contact can begin immediately. We want to dry the newborn and wrap them in a blanket or towel. Body heat conservation is a huge thing for the newborn. And we want to place them on one side with the head slightly lower than the rest of the body. We're going to now clamp and cut that umbilical cord. And so the way that we would clamp and cut it is to go about 2 inches away from the baby's body, and then you're going to put a clamp, and then you're going to go another 2 inches and put another clamp, and then you're going to cut right in the middle of that. All right, and so some people will ask for specific things in regards to cord clamping and cutting. Delayed cord clamping is very popular right now. And it's actually very good for the baby to let as much blood return from the placenta back to the baby as possible. And so that usually takes around 5 to 10 minutes. And so what you would do is just kind of keep the baby at the level of the mom's vagina or put her up on the abdomen, but no higher than that. For those time periods while this is pulsating. And when that umbilical cord stops pulsating and goes limp, it's going to be a lot easier for you to cut. It's very tough to cut through that. So it's going to be a lot easier for you to cut once there's no blood left in there. So you just let all that blood return back to the baby, let the cord go limp, and then cut it. Some people don't prefer that, but it's totally just one of those things that you can ask the parents about if they have a preference or if you have a preference specifically. So then you're going to get your 1 minute APGAR score, and we'll talk about APGAR in just a second, but we're going to get the 1 minute APGAR score. We're looking for the baby's appearance, we're looking at the pulse, grimace, we're looking at their airway, and we're looking at their respiratory drive. And then we're going to prepare to deliver the placenta. And again, remember, the placenta delivers itself usually within just a few minutes. The mom will feel some cramping, maybe the urge to push again, and that placenta should be delivered. You can help by slowing that bleeding down by gently massaging their abdomen with a firm circular kneading motion, and this is called a fundal massage. And so again, if the placenta is already delivered and there's still excessive bleeding, or even if prior to the placenta delivering there is a lot of bleeding, you could consider this. But generally after the placenta is delivered, how you're going to do this is with your fist. All right, so this is not, I know this picture doesn't do it justice, but if you are just making a fist and you're going to put that right into the woman's lower abdomen, and you are going to literally firm circular kneading motions as if you were kneading bread. That's what you're trying to do here. It's not comfortable for mom, it's kind of uncomfortable for you, but that's what needs to happen to slow that bleeding down. Their life may depend on it. We want to make sure that we are recording the time of the birth in the patient care report. That's very important for birth certificates and things like that. And then we want to consider these emergency situations. So if it has been more than 30 minutes since the baby was delivered and the placenta has still not delivered, that's an emergency. If there is more than 500 mLs of bleeding before the delivery of the placenta, or if there is significant bleeding after the delivery of the placenta, all of those are considered emergency situations, and we might need to consider ALS or rapid transport for the patient at that point, depending on the situation. So I'm going to stop this portion of the video here, and I'll catch you in part 5. This was a long chapter.